Breathe in. Hold your breath.
This 60-second screening can help save your life from the leading cause of cancer death. More people die of lung cancer than colon, breast, and prostate cancers combined. Like all cancers, catch it early and the odds of surviving are in your favor. The Morning Medical Update starts right now. And good morning to all of you. It is Monday, April 25th. Thank you so much for joining us right here on Facebook, YouTube, and on Twitter. Dr. Dana Hawkinson will join us here in just a bit with the latest COVID-19 count and the COVID headlines. But first, smoking is not the only cause of lung cancer, but it is a leading factor. A local, well-known business owner shares his story of kicking the habit and why he never misses his annual lung screening test. Get your questions sent in to us on YouTube, Facebook, and Twitter, and at the Medical News Network. Right there, our email address is on your screen. Lung cancer occurs mainly in older people. Most are diagnosed at age 65 or older. A small number of people are diagnosed younger than 45. Cigarette smoking, of course, is a leading cause, and even secondhand smoke is linked to 3% of all lung cancers. Early detection is key to survival. A routine low-dose CT scan of the lungs helps save lives. Joining us this morning on why it is so very important to quit smoking and get those screenings is a man some of you may know for his retail stores here locally and that auctioneer voice that we know. David Nigro Sr. of Nigro's Western Wear joins us from his store in KCK. And here with me in store, here with me in studio is Dr. Nirmal Veeramachanini. He's cardiovascular and thoracic surgery. Also, he is the medical director of the lung screening program here at the hospital, along with Stephanie Oxendale, who helps run the lung screening program here at the health system. And we want to say good morning to all of you. Thank you so much for joining us.
Good morning.
Good morning.
Good morning. David, let's start with you. Hi, Dr. V. How are you?
Good morning.
Good to see you. David, let's start with you. A very personal cause for you. Talking about this, getting the word out, sharing your story with, I'm sure, the public and your customers. Explain to our viewers why this has been such an important message for you to share.
Well, 5 years ago, right around 4th of July, I had like a little stomach problem, so I went to KU. And they admitted me for a couple days, and one night, 2:30, 3 o'clock in the morning, a young male nurse walked in there, and we started talking and just about everything, and he mentioned about me smoking, read right there, and he said, you know, Mr. Nigro, he said, if you get rid of those things, your lungs, you can help your lungs, help your body, and help your life. Well, something clicked after 45 years, and I just threw those cigarettes away on 4th of July and never looked back. And every year I get my lung screening over there at KU, and so far, knock on wood, everything's been good for me. So I feel very lucky and very fortunate, and I think everybody just needs to throw them away.
Wow. Okay. My mind is blown because I've known people who've smoked all their lives, decade after decade. And to think that you heard this news and in an instant you were able to stop smoking. So it was not hard for you at all. You knew this was going to save your life, right?
I did. You know, I mean, don't get me wrong. It was tough because I hung around with a lot of people that smoked, you know, and so I just didn't let it get to me, and I just quit hanging around them for about 6 months or not as much, and I just heck with it. You know what I'm saying? And I don't complain to them, and because they are big boys and big girls. So I mean, you just got to do it on your own. Is how I feel about it.
I love that you said that. You took that factor out of your life, and I bet your friends appreciated it. I bet they were there to support you, to say, hey,
they did.
Right? I bet. What kind of impact, though, did
exactly.
You're an auctioneer, so your voice is everything. How did that affect your auctioneer job?
It never did bother it, you know. I mean, I don't know what it was. It never did. I mean, we all got big mouths in our family, it seems like, especially our guys that do all the auctions. So it's not like you can't hear us, you know what I'm saying? So, but I mean, after I've quit smoking, I noticed just walking, just exercising and doing all that, I can do it better and I can breathe better. And that makes a big difference. And I can run around with my grandkids. So it makes a big difference. It really, really does.
Fantastic.
So I'm glad I quit. I'm glad I quit.
We are too. A total life change, it sounds like. Dr. V, I want to bring you in here. And how did David just he came here to the University of Kansas Health System, and what kind of condition was he in, and how did you know you could help him?
So I
didn't really get involved in his care a whole lot because we have it set so our primary care providers, when they see patients, they can refer patients who are eligible for lung cancer screening into our program. So in the current guidelines, so anyone who's smoked more than 20 pack years, if they haven't quit within the last 15, and the reason that 15-year requirement is important is when you quit smoking, your lungs start to heal a little bit. I mean, if you still have smoking-related damage, the damage is done. The rate of decline of your lung function, however, slows down a little bit. But in terms of cancer risk, after about 15 years, the data indicates that your risk of lung cancer is similar to the general population. So if you're a recent smoker, you're still smoking within the last 15 years, and you're over the age of 50, you can get referred into our program.
You're calling this a paradigm shift, though, that's happened in the last 2 months when it comes to lung health, correct? Explain to people what that is. This is really, I mean, lack of a better term, game changing.
Right. So the concept of lung cancer screening is not a new one. So going back to the 1960s and 1970s, people were trying different strategies to detect lung cancer early. We've tried everything from getting chest x-rays, which don't work. So you really need a CT scan. So in the late 2000s, we got the first clinical trial after 30 to 40 years that showed that you could reduce your risk of cancer death by 20%. So mammography is important, colonoscopy is important, but nothing is as impactful for cancer prevention and cancer-related death like lung cancer screening.
Based on right now.
Based on right now. Then within the last couple of years, the Europeans have added to the data that shows that in some groups of patients, you can reduce lung cancer-related death by up to 40%. This is especially true in women.
I want to talk about women. You said this is this going to impact women, African-American women in particularly? Tell us why. So
the prior lung cancer screening guidelines that are based on the National Lung Cancer Screening Trial, it tended to be more Caucasian men. They tend to smoke longer and more. So that's where we got the idea of the 30 pack years and the age. Well, if you look at the data, women have more to benefit from lung cancer screening and early detection of lung cancer than men do. And just because they tend to smoke less, we weren't including them. So the guidelines from the U.S. Preventative Task Force has shifted. So we're being a lot more inclusive and getting a lot more people now eligible for lung cancer screening.
Stephanie, let's bring you in and let's talk about David's care. He was referred to the program, as we said, from his cardiologist to get screened every year. I know Dr. V credits the care that our patients receive to this group of folks, right, Dr. V? He sings your praises to get them well. Tell us a little bit about David, his case, and how you walked him through the program.
Yeah, so David specifically was referred by his cardiologist, but other patients can come in a variety of different ways. You can even self-refer to the program just going to the internet and typing in Lung Cancer Care KU, and you can actually fill out a form and get referred directly into the program, and we'll take it from there. We'll order your CT scan, and we'll get you seen. We'll do a shared decision-making to make sure that you understand the risks and benefits of the program, and then we'll get your scan completed that same day, and we'll get your results that same day as well, which is pretty phenomenal. And then with David specifically, he'll qualify for the next 10 years to have annual lung cancer screening done, and we'll get his CT scan completed. And he's a great example of how important it is to come every year just as part of that preventative health care and make sure that we get him taken care of and screened.
David, let's bring you back in here. And you said it. You said you have a big voice and you have all these people that come into your store. And how much do you use that platform and that opportunity and just your name and voice in the community to share, certainly not just to sell Western wear, but to be able to help save people's lives and help advocate for these lung cancer screenings?
Well, I think when people hear, that, I smoked for 40 years. So you can do it. You can break any habits you got. You just got to put your mind to it. What I believe is what you can't do. You can't have somebody preach at you to tell you got to stop, you got to stop. You got to do it yourself to make it work. And if you do, your whole life is going to be a lot better. I can guarantee you.
So tell
that's
me,
and then everybody over at KU is taking care of me.
well, tell me a little bit about the process for you when you come to get your screenings and your scans. Maybe someone who's not familiar with that, tell them what that process is like for you so they have a better understanding.
It's nothing. You just walk in a building. They take care of you. They do your screening. You talk to your doctor for a few minutes, and then they'll call you back and tell you everything what's going on with your body. It's nothing. Everybody should do it. It's a piece of cake. It's a walk in the park. Everybody should do it.
Okay, he's like a very
yeah. So
David,
David,
you need to put him on the payroll.
Yeah. So a couple of things. So people get scared of scans and so on. So a couple of things. Like nobody likes to get blood drawn or an IV put in. Does lung cancer screening require that?
No, it didn't require nothing. I mean,
Right.
just take your shirt off. It's no big deal. I mean, I don't like getting poked and prodded either. Okay, they'll all tell you I'm a big sissy when it comes to that.
All right.
But you got to do it. I mean, you got to do it to take care of yourself.
Yeah.
And you got to
so-
do preventative maintenance. You change oil in your car. There you go.
And how long did the process take you? Like last time you came in for your scan, how long did it take?
20 minutes. Everything from
Okay.
start to finish. 20 minutes. So
Dr. B,
that's
how long will
nothing
he
to
be
check your
doing
body
these?
out and make sure.
Is this year after year?
Year
This
after
would be
year.
this would be my sixth one coming up. I think it's in June or July. Yeah, this would be my sixth one.
Yeah. So I'm going to stress the importance of continued screening. So oftentimes, if you look at the data, so people come in, they get their first scan, and it looks like they're completely normal. Unfortunately, the little nodules and such that turn into cancer, they evolve over time. So this is really important of why you need continuous CT imaging year after year. Current recommendations go up to 80. I should take a little pause to say that even in patients who are getting a little frail, who might think, even if I have lung cancer, there's no way I can tolerate an operation. Well, we have things that we can offer patients that don't involve surgery per se. We have stereotactic radiation. We have other ways of treating this that can be life-saving, that can deal with even patients who have other comorbidities that may make them too frail for an operation.
So Stephanie, tell me this. So with David, he's been smoke-free. David, how many years? 5, 6, 7 years smoke-free?
Be 5 years, 4th of July.
Congrats on that.
Yeah,
5
5
years.
years.
So does that mean that he'll always need this screen? He's high risk because he smoked for over 4 decades. But is he going to continue? Will at some point he not need this screening, or is it best for him just to get one every year from here on out?
He should get one every year until he hits that 15 years of smoking cessation. That's when we see the risk benefits change. So he'll get it for the next 10 years. Come in and see us.
All right, another community question for us today. I want to get to this one from Cindy in Independence. If your parents were longtime smokers in your house, here's that secondhand smoking question. Are you at risk and maybe not know it? How at risk, Dr. V, is someone who grew up in a house with smokers? I know I did.
Certainly there is increased risk, but nobody really knows how bad that risk is. So currently the guidelines don't use secondhand smoking exposure as one of the criteria for lung cancer screening.
Okay. Do you think we ever will?
We may, and I think in the future, if I had to take out the crystal ball, I think in 5 to 10 years, we'll probably convert to a blood test, for example, and we might have some sort of proteomic signature. We're doing a couple of studies on that. I think that's probably the future to enrich the patient population. The reason you just don't want to scan everybody, that's the $1 million question. So somebody's parents smoke, so how come they're not getting a scan? Well, the problem with especially living in the Midwest is you find lots of little nodules, you find little granulomas, you find exposure to the environment. We have Dr. Hawkinson here. He can kind of attest to how we're in the middle of the histoplasmosis belt. Yep. We have all these soil bacteria that we ingest. So you're at risk for finding things that are not cancer that lead to invasive procedures and such. And this is why it's really important to come to a program where you have dedicated chest radiologists and an entire team centered around this. So people who can better predict when a nodule is more likely to be cancer versus not, because you don't want unnecessary procedures.
That was my question. Is the idea to try to avoid invasive procedures
Correct.
at all costs?
Correct. It's a quality control measure. So, for example, when in our program, there are lesions that look like lung cancer, and we will operate on some of these because you can't biopsy everything, and sometimes you just have to operate. But our rate of removing benign things is extraordinarily low, and we try and keep it that way.
How accurate are those 60-second tests that David's been taking, and what is it exactly looking at?
So what you're trying to find on those scans is nodules or lesions that may mimic early stage lung cancer, which then results in further workup. So if you find a spot, it doesn't mean you have lung cancer. Only about 2 to 3% at most. It depends on which patient population area. If you're in northern Kentucky, for example, where people really smoke, I have a colleague of mine who runs a lung cancer screening program there. So in his program, of the spots, 2 to 3% of them turn out to be cancer. In our area, it's closer to 1.5 to 2%. It's still high, and you can be very impactful, but most spots are not lung cancer. That I need to stress. But it's going to require some careful follow-up and attention to working them up.
Well, this geography lesson is interesting. Missouri continues to rank in the top 10 states with the most smokers, so that's telling us something.
Yes.
Interesting. All right, let's get to Dr. Hawkinson. Let's talk a little COVID count. Right. Medical Director of Infection Prevention and Control with us today. How are you?
Hi, I'm good.
Good to see you.
Yeah, good, thanks. It was a nice weekend.
Yeah.
So right now here at the health system, we have 8 active infections, 2 in the ICU, none on the ventilator, still 13 in that recovery period. Again, overall, what we see in the United States as a whole is a continued slight increase in cases, although the case burden still remains very low, and a slight increase in overall hospitalizations throughout the U.S. as well. Again, probably mostly centered on the Northeast, as they seem to see this most recent uptick in cases a little bit earlier than other places. But right now, still at our health system, it's looking pretty good. Again, 0 would be the best, but we can hope for these single digits as long as possible.
A couple quick COVID headlines that just came out I wanted to ask you about. The drive to vaccinate the world against COVID, losing steam. You feel that same way?
Yeah, I mean, it's hard. You know, our point of view here in the U.S. is quite different. And again, every country has a different experience with coronavirus for sure. But I feel that probably is true. But we know that there are so many countries, so many areas that are less fortunate than us as far as having that supply of vaccine. I think if you went to some of those other countries that have not had as much supply as we have here in the United States, a lot of those people are still going to want to uptake that. But then you also have to compare that with other cultural issues and other issues such as people who have been infected and maybe reinfected throughout this as well.
So there was a CDC panel that said that they were skeptical of 4th COVID shots for the broader population. I'm assuming that's those over 50.
Yeah.
Says that the U.S. now needs a clearer strategy when it comes to the vaccine. What are your thoughts on those?
Yeah, I mean, I think we will parse that out again as we are continuing to move through this. We never had that 0 COVID policy in the United States. We've never had the shutdown, so we do have some population immunity by infection and reinfection. Most of our immunity is that safest kind of immunity that's been obtained by vaccination. Now, again, the big question remains is who needs that 4th dose? Is it everybody? Obviously, we know some of what went into creating that recommendation of 50 and above getting that 4th dose is because a large percentage of that population, 50 and above, continue to have those comorbid conditions. But this is one thing that continues to be expressed, one argument that continues to be expressed by experts. Do you need that 4th dose? Do you not? We know that those 3 exposures to spike protein, whether that's through boosters and vaccination or vaccination and infection, we know that is really important for helping expand those B cells and those antibodies so you can create those antibodies that are able to neutralize the variants that we know about, and more than likely even some variants we don't at this point. But again, I think the saving grace continues to be that when you have those 3 exposures to the spike protein, again, through vaccination or infection, we still get that expression and that expansion of those T cells, which are very vital in helping protect you from hospitalization, severe disease and death. So again, I don't think the book is fully written on this. We will continue to update as we get more information on third versus fourth dose, and maybe even more in the future if that is a recommendation.
If you're just joining us, David Nigro Sr. of Nigro's Western Wear joins us from his store in KCK. And here with us in studio is Dr. Nirmal Veeramachanini. He's a cardiovascular and thoracic surgeon. And also Stephanie Oxendale. She's a nurse practitioner. And we are talking about our lung cancer screening program. So, Dr. V, I want to just ask you first, where do we stand with immunotherapy and lung cancer?
Sure. So, in the last few months, we've had a paradigm shift in how we systemically treat lung cancer. So, the old paradigm used to be, if it were early stage lung cancer, you'd get an operation, and then we would just follow you. You wouldn't necessarily need chemotherapy, because what we had was fairly nonspecific, and the absolute benefit was really small. But it was a real difference. So in a lot of patients, we would recommend chemotherapy even after a good operation where, quote, we got everything out. But the problem with lung cancer is that, and like other cancers, it's really a system-wide problem. So lung cancer does spread. Mm-hmm. So even in a lot of early-stage lung cancers, people recur, and it happens about 10 to 15% of the time. In the last 10 years, we've had a paradigm shift in how we treat cancer, and our biggest improvement in patients surviving, even when they have stage 4, they have metastatic disease to brain or elsewhere, they're still around for a long time because we have drugs that are immunotherapy agents. And what these drugs do is they expose the cancer cells to your own immune system. That's a very simplified response, but basically your immune system is then able to counteract it. So what's happening in the last few months is we now have data that says you can start patients on systemic therapy even before the operation, even when they're early stage. So to the patient out there, it may take a little convincing to say, you know, we know you've got a cancer, but we're going to wait about 6 to 8 weeks and actually treat your body first and then take it out. But it's actually important.
You said that Dave is like the poster child. He said he's the perfect example of why these screening programs are so crucial. So just tell us why. We're talking about somebody who smoked for 40 years. They've been smoke-free for 5 years, and he's actually a really good patient, comes in to get his screenings.
He's a wonderful patient. And the reason this is important is your ability to say you've cured somebody is going to be exponentially greater if you catch these at an early stage. When patients have lung cancer that spreads to the lymph nodes in the center of the chest or elsewhere, it is much more difficult to treat. And that in those conditions, you're often treating a lifelong condition where they're getting continued maintenance chemotherapy or something. And they can have an excellent quality of life. They can go about their business for a long time. But if you catch it really early, you're more likely to be able to use the C word, the cure word.
Right, the good C word.
The good C word. So that's why it's really important. So if you're at risk, get screened, because you're at higher risk. And if you do have it, the chances of saying you are truly cured is much, much higher.
I want to get to some community comments and questions. And one, David, is from Vicky. She says, way to go. So happy for you that you quit smoking and stuck to it. Ruth Ellen says, grandchildren were a big factor for my husband to stop smoking 5 years ago. They didn't ask him. He just knew that the smoke would be on him and affect them for a long time. You mentioned a little bit off the top of the show, David, but what are you enjoying most about being a former smoker?
Just that I'm exercising. I like to walk. I can breathe better when I'm walking, even around the store, talking to people. I don't stink. You just don't have that smell. And food tastes better, and just everything's better. And I can breathe, and that makes a difference right there. I can breathe, and I want to keep living, and I'm going to keep listening to the doctors, my internist, and Amir and Stephanie. I'm going to keep listening to them, and I'm going to take care of myself. So that's my thought on it.
Jennifer wants to know, and Stephanie, I'll ask you this, what makes this particular program unique? Is there anything unique about this program that maybe somebody might not find somewhere else?
Well, our program is unique because of how team-centric we are. So you'll get your shared decision-making the same day you get your CT scan, if that's what you prefer. You get your CT scan right away. And then what's very unique about us is that we give you those same-day results. Typically within an hour, we're able to get those results to the patients. And we can work through all of the things that we're finding and then also explain those in detail to the patient.
Getting screened and getting results immediately,
So-
that's key.
We're also blessed. Our radiology team is phenomenal. Our section of chest radiology at KU, we have 5 dedicated chest radiologists. They've really specialized in this. They're really good, and it's really important to have a lot of consistency. So the reports read the same way. It's the same set of eyes. You get a lot of internal consistency, which is really important for lung cancer screening.
Jean wants to know, do lung granulomas turn to cancer? I have 2 in my right lung.
If it's truly a granuloma, no. What will likely happen over time is they'll tend to calcify. So on a normal granuloma you might not see on a chest X-ray, but over time you'll get this little bit of calcification on it. It'll look like a white spot on a chest X-ray.
Okay, question from Lori. What about the difference between small cell and non-small cell?
Okay, in terms of cancer biology, they're both lung cancer, but they're both different flavors of lung cancer, if you will. Small cell lung cancer has historically been a bit more aggressive, and the standard treatment options that we use for non-small cell and small cell are different.
Got it. Okay, question. So Judy has a comment. She says, everyone, if you are or were a smoker, do this because Medicare pays for it. True?
Yes.
True. Okay. She said she was in and out in 15 minutes, like David had mentioned. There's no shaming or lecturing if you still smoke. Just get in and do it and don't feel ashamed. David, that's where I want to bring you in. You said you try not to preach to people, but it's hard not to preach good health and quitting smoking and how well this has worked for you and how you were able to do it. You really have a story, my friend. You do, and it is worth sharing it with people that you come in contact.
Well, I don't know if it's a story. I just, everybody, my kids, my wife, everybody was on me about smoking. It's just something you got to make up your mind. And like I said, when I was talking to that nurse there at KU that night at 3 o'clock in the morning, just watching TV, you just had, all of a sudden, you just look at your life and say, man, what am I doing? You know what I'm saying? And this guy, I've never seen him again, and we'll never, ever, our paths will never cross again. And just when he told me, he said, you throw them things away, your lungs will start healing. Something clicked in my mind, and I did that, okay? And I wish I knew who the nurse was. I mean, if it is, I'd buy the guy a steak dinner. Just, I guess, because it was a total stranger in my life that helped me. You see what I'm saying? Just listening to him, okay? So that makes you just got to reflect on things and see what's going on with you. That's what you got to do. That's what I think. So that's what people got to do to straighten the mess out. And then get all your check-ins. Get your lung screen, your colonoscopies. You just got to do it all today.
We need to have him on every day
Yes.
to talk to people
Yes.
and to encourage people to do screenings or just encourage them to do almost anything. I know it is a story because you're such a great person and advocate, and we appreciate that. Stephanie, what's it
Thank
like
you.
to work with someone like David and to know that you're helping them and that you're helping guide him down the path of better health and being around for those grandkids and family members?
Well, it's great. It's to be a part of David's story and to be a part of other patients' stories that have really taken their health seriously. And we're here to help. We're not here to judge. We're here to walk you through the steps and to be assistants to each patient in their own journey. So it's rewarding, especially with patients like David who have been able to stop, continue to do the right things, get their screenings done.
Dr. B, Kathy wants to know, do primary doctors promote this the way they might promote a colonoscopy or a breast cancer screening?
Certainly they do. What's different for this screening program versus colonoscopy or mammography is that it requires a lot more documentation and work. So verifying that patients are truly at risk, meet all of the requirements, and they have this detailed conversation about some of the risks of finding things that are not cancer and the lifelong need for this, it adds a special burden. So CMS used to require what they call a face-to-face conversation that we'd have to document. That's part of the reason we've centralized this whole lung cancer screening program at KU. Our nurse practitioners have that discussion before we put the patient in the scanner, so they understand what's in store for them for the next 10 to 15 years of their life.
Anne has a question. This will be our last question. I'm going to just read her story and then you let me know what you think. I had a cardiac calcium score, which was at 0, but they saw 2 small lung nodules. I have no history of cancer, but both my parents smoked. I'm 70 years old. Should I get a follow-up?
Absolutely. So depending on what those lesions look like, we might consider them completely benign, but one has to remember that a good percentage of patients who have lung cancer are never smokers. So that's very important. Yeah. So unfortunately, people get scans for various other reasons and you find spots. So that's important to get followed up.
So it's important just to keep asking your doctors questions and making sure they're asking you the right questions.
Right.
Be your own health advocate. All right, we're going to get to some final thoughts today. Stephanie, I'm going to let you start with us and share what you want folks in the community to know.
What I want them to know is that they don't need their primary care doctor to refer them to the program here at KU. They can do it all on their own. They can just call us and we'll get them screened and scanned if they meet the qualifications. And I also want people to know how the guidelines have expanded to include so many more patients that are at risk, and how much good that we can do and help them in their journey, and to be advocates for their own health as well.
Good. That's a great piece of information. You can pick up the phone and make your own phone call and get screened or get tested to get screened. Dr. V, we started out the show just talking about this paradigm shift. Kind of wrap it up with us so we understand how important and how much we've moved the needle in the last couple of months even.
So we've done some amazing things with lung cancer. So we now have clear guidance on how to detect it at an earlier stage. And now we have therapeutics that can really stop the spread of this or really improve long-term survival, even if you do have lung cancer and even if it is at an early stage. So how we interact as a team has profoundly changed. So we're urging people to get scanned. And if we do find it, and they do have lung cancer, we have both surgical, radiation, as well as chemotherapy options that all really make a huge difference for decreasing mortality. And it's about decreasing mortality, and that's a key statement.
Always good to see you. Thank you so much. David, what a fun guy to have on our show this morning.
Well, I appreciate you guys having me. I really do, and I do appreciate it. And I appreciate how you guys take care of me over there, too. I really do, with all my doctors. I feel blessed to have you guys in my corner.
Well, thank you. And just, David, what's your final message to anyone who might be listening today?
Stop smoking. You can do it, and don't even start. That's your best thing right there. Don't even start, but you can do it. If you put your mind to it, you can do it.
I'm just going to send people over to Nigro's. Go to Nigro's, bump into David. He will motivate you in ways you've never dreamt possible. Thank you so much, David. Please stay in touch. All the best to you.
Thank you, folks.
All right, Dr. Hawkinson, you've got to follow David Nigro. What do you got for us?
I don't think you can follow that. I think it's just great, sage advice. It's something we try to promote here at the health system, and that's being up to date with your screenings, your vaccinations, all of your primary care. I think there was a good question about that earlier from the community about should the primary care physicians be doing that. Absolutely, yes. That's one of their main jobs, is to keep up with those recommendations for screening, because doing that early saves so much morbidity and heartache and tragedy down the road. And so, again, I think nothing to do but echo David's sentiments.
Yeah, don't even start. Yep. Don't even start smoking. Thank you all so much for being with us today here on Facebook, Twitter, and YouTube. You can catch our shows anytime by logging on to those media channels. Everyone, have a great Monday. Coming up tomorrow on the Morning Medical Update. Skippy may be his fame name, but the life of this popular KC music man wasn't always in tune. Skippy's connection to transplant and what he wants you to know. Tuesday at 8 on these social media channels.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.